evening, everybody, and welcome all of you to the live program number 115 at Orthopedic Principles. We are back with our stellar faculty, Dr. Krishnakiran Eachampatti from High-Tech City, Hyderabad. As you have seen, Krishnakiran is very well versed in complex and revision as well as primary total hip and total knee replacements. You would have seen his earlier lectures, really complex cases, and those were well received by the audience. So today he's going to talk on removal of well-fixed components in total hip arthroplasty. Over to you, Krishna.
Thanks, Hitesh. Thanks for having me. So we will look at the removal of well-fixed components in total hip arthroplasty, with the focus being on the femur. Acetabulum, we all know, has become reasonably simple with the explant device, but femur continues to remain a challenge, and especially with the different types of femoral implants, there is still a lot of confusion as to how we go about this particular problem. So the basic question is, when is removal of well-fixed components required? You will need it in cases of component malposition, places where there is hip instability which needs a full revision. If you have anterior thigh pain because of one of the distally coated implants which is severe enough to warrant revisions, some revision will work. You may have to do a both component revision, that is when acetabulum as well as femur need to be removed, and you must be prepared with the full set of armamentarium. Again, situations where there is an aseptic loosening of the acetabular component, but it is not necessary that the trunnion is all right. So if the trunnion is damaged, then it will require to be removed. There, the offset and leg length needs to be altered because of component malposition and failure. Cases with broken implants, like broken trunnion in this particular case of a metal-on-metal total hip arthroplasty with an AML stem. And this is one of the common reasons we will need to revise a well-fixed femoral component, and it's a nightmare revision because the component is fully porous coated and it's extremely difficult to retrieve. And this is not an uncommon problem because of the 9-bar 10 taper of the AML stem, which was used in the mid 2000s and up till 2007-8, where in combination with a large diameter metal-on-metal head. So this large diameter head would cause fretting and fracture of this trunnion over a 10-year period. Now, the well-fixed acetabular component needs to be removed in cases of infection where the femoral component is loose but the acetabulum is ingrown. The acetabular revision is relatively straightforward, so I will not dwell into the details of that. But in today's age, if we don't have the explant device, which are a set of spherical blades, a small and a large blade, which is supplied by the Zimmer company for acetabular revision, then it is not standard of care. So you must have the explant device, and usually you'll be able to get away with a 2 or 4 millimeter larger socket than the primary. So you will be doing a bone conserving implant removal for the acetabular side by using an explant system, and I would urge all of you to get this system, get familiar with it whenever you're attempting a removal of a well-fixed acetabular component. Now, the key principles are good quality radiographs to identify the type of implant which has been used previously. What is the quality of bone? Are there any defects related to osteolysis? One must always exclude infection through ESR, CRP, if appropriate aspiration. The incision must be planned based on the pre-existing incisions, what you are familiar with. The approach and safe adequate exposure must be the primary concerns when attempting retrieval of implants. The key step is to remove the implants with minimum bone loss, avoid iatrogenic fractures and cortical perforation. So you must be ahead of the game, make your plan and do the surgery properly so that you don't cause additional problems to the patient. Don't forget to preserve the soft tissues, especially the vascularity around the femur whenever we are doing an extended trochanteric osteotomy. The abductor muscles and all the soft tissues must be preserved. Have access to bulk allografts, morselized bone grafts wherever appropriate, and full set of removal kits and appropriate implants for reconstruction must be kept on hold. Now, the femoral implant removal can be classified based on the different types of stems: the HA-coated stems, the grit-blasted stems, proximally coated stems, fully porous coated stems, modular stems, and cemented stems. So we will look at case examples for each of these things and go through the key steps for retrieval of these implants. Now, the HA-coated stem or the grit-blasted stem is an on-growth type of device. We must differentiate between on-growth and in-growth. So wherever you have HA coating or grit blasting, there is on-growth of bone, and these stems are usually fully coated. So its example is the Zweimüller stem for the grit-blasted stem, and for the HA-coated stem, it's the Korai stem. So the first strategy is to expose the hip, release the lateral shoulder and medial calcar with an osteotome to break the cancellous bony bridge. You can remove 5 to 10 millimeter bone under the collar in collared stems to get access. Then you use K wires to separate the implant bone interface, and this must be done carefully and slowly. And you now have the femoral explant for extraction of the implant. So this is how the femoral explant looks like. You have the surface which is facing the implant bone interface and the surface which is facing the bone, and gently you pass it on the proximal part, free the proximal part of the Korai. Usually the Korai fails because of distal fixation, so the proximal part is already loose. And if you remember, there are vertical serrations along the distal aspect of the implant, and you can easily pass K wires to break the bonds between the HA coat and the bone by passing K wires in all the directions. And then you use an instrument or a retrieval instrument with a slap hammer attachment to hammer this implant out of the way. So this is a intrapelvic protrusion of the cup, and the stem is in varus malposition, and because of the intrapelvic positioning, the trunnion is damaged in this particular case. Sometimes you will have to do what we call as a limited posterior slot osteotomy to retrieve the components. You don't need to do a full ETO. You just do a limited longitudinal slot along the linea aspera. So you put a cerclage wire distal to the proposed linear slot, make a linear slot osteotomy that will loosen the stem out, and without doing an ETO, you can remove it. And usually you can use a 190 millimeter Wagner type of stem to reconstruct this particular surgery. So the key step here: use the femoral explant, use K wires along the longitudinal ridges, and use the limited posterior slot femoral disruption of the implant bone interface and easy removal, so that we can use a 190 sort of stem and leave the modular stems, the longer stems, for a subsequent revision surgery. Similar principles apply for the Zweimüller stem, which is a grit blasted on-growth stem again. So the on-growth stems, easy to disrupt the interface between the implant and bone proximally, K wires distally, and wherever indicated, do a limited posterior slot osteotomy to loosen up that implant. Do a prophylactic cerclage wire distal to the proposed slot osteotomy, and you will usually be able to get away with a 190 millimeter Wagner stem and remove the bone implant without much bone loss. For the proximally coated stems, you must again have adequate exposure of the shoulder and medial interface. You can use a fine flexible osteotome or do a proximal femoral osteotomy to the extent of the coating. So you can make a plan. You don't need to do an extended trochanteric osteotomy like a standard ETO, but you can do a proximal limited osteotomy to get access to the coated area, and then carefully remove it, and then you can use again a 190 millimeter Wagner to reconstruct this particular implant removal. Advantages of osteotomy: it's a controlled maneuver and the bone loss is less. Any deformities in the proximal femur can be corrected. So varus remodeling, if it is present, especially in the setting of a cemented stem, the ETO is an indication. If needed, stem can be sectioned and the distal stem removed by trephining. So this is not required for proximally coated stems. So this is an example where there was an infection, long-standing infection. You can see a sinus going into the bone, and this is a proximally coated implant. The technique which was described previously, and an antibiotic spacer was put in, and in a second stage we could use a proximally fixing device like an SROM to reconstruct this particular defect. The fully porous coated stems now are the most difficult ones to extract, and it is mandatory to use an extended trochanteric osteotomy routinely. And we must carefully plan the length of the osteotomy, because there is no point in doing a half-hearted osteotomy. You must do the osteotomy to the length of that particular implant, because you cannot remove it otherwise. There is always a compromise between access to the stem and residual remaining length of bone for fixation of the revision implant. So this must be tailored individually, and you must be prepared with stem transection devices. So you must have metal cutting burrs and trefines. So you have 12, 14, 16 hollow mill type of trefines available in the revision set. So you can transect the stem, remove that stem at the level of the osteotomy if it is too long, and then the remaining part of the stem can be removed by using these trefines passed over the top of the remaining cylindrical part of the stem. So other strategies have been described, like longitudinal femoral osteotomy and the transfemoral osteotomy. And these are the techniques where they've described anteromedial windows, which has never worked in my own hand. So I've always had to do an extended trochanteric osteotomy while removing the fully porous coated stem. And some studies have said that you can just do a transverse osteotomy distal to the stem and do a controlled segmentation of the proximal femur, make it into multiple pieces, remove the stem, put a new stem, and wire all these around the proximal femur. So this is not uncommonly done. It has to be done sometimes, or it happens intraoperatively when it is not coming out. So case example, where you have a fractured trunnion, so there's no choice but to replace both the cup as well as the stem, and it's a fully porous coated implant. So we had to do an extended trochanteric osteotomy, and you can see we put a prophylactic wire distal to the exit of the osteotomy, and it was a relatively long osteotomy, extending up till the distal limit of the porous coating. And then once we were able to remove the stem, we reconstructed it with an adequately long Wagner stem. So it must bypass the osteotomy by at least 2 cortical diameters. So around 4 to 6 centimeters of bypass is required. And this is a grit blasted titanium device which has got distal fixation, and it's got flutes, and this is a 4-year follow-up showing good incorporation and healing of the extended trochanteric osteotomy. Now another case, because the AML stem fully porous coated is very difficult to revise, we chose to retain the primary stem, and we did a revision by retrieving the cup and then did a dual mobility socket, because this was a recurrent dislocator, and this patient had dislocated after a liner exchange and head exchange was done elsewhere. And this came with a disengagement of the head from the trunnion, because obviously there was trunnion damage which we missed intraoperatively. So this required again an extended trochanteric osteotomy followed by a distal bypassing stem. So we used a long solution stem. So these stems are difficult to remove. They'll take at least 3 to 4 hours time, and you must be careful to not damage the residual bone proximally, and you must put it back together in order to have a successful outcome and in order to preserve the femur as much as possible. Another example where a hip DHS failure was treated with a constrained hip replacement with a solution stem, and this dislocated, and luckily for us this stem was loose, but you can see that this is really a challenge, because this, if it had ingrown, would require a complete femoral approach and a sort of a resection of the implant, as I showed you, cutting the implant out and using trefines to go around the stem and remove it carefully. And these will always require modular reconstruction options like a reef, where we have an interlocking option distally and ability to adjust the offset proximally. The modular femoral stems again require specific extraction devices. So you have to disimpact the stem from the proximal sleeve And second step, extract the stem interdigitated with host bone with K wires or flexible osteotomes. And sometimes you may have to do an extended trochanteric osteotomy. So this was an example, a stem in sleeve type of construct, which was done around 10 years back. You can see on the left side that the stem was placed intracortical and there is remodeling of the cortex around the stem, and this became extremely painful after 10 years of surgery. So this required doing a femoral osteotomy, extended trochanteric osteotomy, and removal because of this particular cortical remodeling which happened around the stem. So this must be recognized. And this is a very small patient who is around 45 kilos, and the femoral canal is only 9 millimeters. So we were only able to reconstruct it using a similar sort of long stem, the modular stem in sleeve construct. So we had to wire the proximal femur back, which was osteotomized, and then use the sleeve into this wired fragment. And this patient is around 4 years out and doing pretty well. Lastly, coming to the cemented stems, again, if it's a good cement mantle and it's a collarless, polished, tapered stem, one must definitely consider removal of this stem and a cement in cement or an in cement revision to be done. However, if the cemented stem is loose, then the removal of the cement with reconstruction using a cementless implant is now the standard of care. Precautions: adequate exposure and removal of cement at the shoulder is mandatory. Otherwise, when you are trying to bang the stem out, you will cause trochanteric fracture. The attempt at extraction of the implant is only after disruption of the implant cement interface. But with a collarless polished taper, there is no implant to cement interface. Usually it is loose and it will come out. Always stay close to the implant with osteotome. The femoral extraction device or punch is used to bring the stem out. This is valid for the composite beam type of designs like the original Chanley, where there is some and some of these had coating on the implant to get bondage with the cement. Usually these come out along with the cement because it loosens at the cement bone interface. But if it's a collarless polished taper, it will get the stem is usually loose. It can be just banged out. So you can have two options for removal of the cement. You can do an endofemoral removal, which will require long time, ultrasonics. You will have to have special instruments to disrupt the cement bone interface, and also have C-arm control to remove the cement from endofemoral approach. Sometimes, if there is a well-fixed distal part and cement beyond the femoral bowing and bony deformity in proximal femur, it may be a better idea to do an extended proximal femoral osteotomy to start with. Now, cement in cement revision technique is an option, as I told you, if there is good cement mantle. So this is an example of a well cemented bipolar which has a broken distal part. So the proximal part will be relatively easy to remove, but the distal part will be difficult to remove. So now you have two options for this. You can either make a cortical window and take it out, or do an extended trochanteric osteotomy, which will facilitate removal of this entire cement in an easy sort of way. So the ETO was done. So the principles of ETO: put an encirclage wire distal to the planned length of the ETO. The ETO is usually 1.2 to 1.4 centimeters long. Sorry, it will be around 12 to 14 centimeters long, and you must retain part of the isthmus for the new stem to be fixed. But occasionally you may have to plan the length based on the implant that you are planning to remove. So this ETO is done either through a posterior approach or through an anterolateral approach, and must be done using multiple stacked osteotomes and using an oscillating saw. And you must always put a distal encirclage wire distal to that ETO in order to prevent accidental propagation of the fracture distally. And this must be bypassed by at least two. Osteotomy is usually stabilized using 3 or 4 encirclage wires. Another example, a well-fixed cemented Thompson's prosthesis. No point in wasting time, so you must do an extended trochanteric osteotomy. It facilitates removal of the cement easily, saves time, and again the same principle: distal protective encirclage wire, ETO to the length of around 12 to 14 centimeters, removal of the implant and cement, and bypassing using a distal femoral fixation device like an AML or solution or Wagner, bypassing the osteotomy by 2 to 4 cortical diameters. Now, as I told you, we can use alternate strategies, especially when there is no bone cement. So you just have a loose implant. There is no cement to be removed. You can just do a cortical window and then remove this and then bypass it with a distally loading device. So that was what was done. No ETO, just a distal cortical window which was repositioned back. Again, prophylactic encerclage wire is an important component of any revision surgery. So when in doubt, do a prophylactic encerclage wire distal to the osteotomy or planned osteotomy. So the take home message: identify the type of implant that needs to be removed. On growth stems like HA coated stems or these Weimmuller stems can usually be removed without ETO. All that you need is a femoral explant and multiple K wire technique. Sometimes you may have to do a limited posterior femoral slot osteotomy, which I described. Whenever you do that, you must put a prophylactic cerclage wire distal to the proposed exit site of that osteotomy along the linea aspera. The porous coated stems will definitely require an extended trochanteric osteotomy, and you must plan for the special equipment like metal cutting burrs and the trifines to remove in worst case scenario. The well-fixed cemented stems are amenable to cement in cement or in cement revision. If you want to remove the cement and then do a long femoral stem for some reason, the options are endoluminal removal of cement, which will require special equipment and a lot of patience, and extended trochanteric osteotomy, which is an option in cases where there is varus remodeling, where there is a good cement bone interface and you can't do a cement in cement revision for various reasons. The ETO is an option. You can also do an ETO when there is a lot of proximal femoral widening because of osteolysis. Then you can do an ETO and then compress that bone together, and this will form a good new bone formation and will also help in vascularity. ETO is also indicated in the presence of broken implants. So this is a decision which one has to make preoperatively, plan and execute well intraoperatively. The key step is to preserve bone stock which is residual after the removal of the implant. So this will allow us to do the most conservative femoral revision possible, so that after next 15-20 years we still have some option or implant available to bypass this particular revision surgery which we have performed. Thank you.
Thank you, Krishna, for yet another crisp and concise lecture. A few questions.
Yeah.
One is, see, how do you identify the implant? See, for example, you don't have the operative notes, or it has been done in a totally different country. Is there, I remember having seen a software where you just need to take a picture and upload it, and that will help you because it has a matched series of implants. Do you rely on something like that?
I don't rely on that, but I have also seen such a software which is available, and a lot of people are trying to get a comprehensive software which will identify all the possible implants. But I'm not aware of any such comprehensive thing available. For me, I've been doing orthopedics for last 20-22 years now, so I've seen the whole set of implants. So by looking at the X-ray, I can actually figure out what implant it was. It's very unlikely that we don't figure out. It happened a couple of times when it was a furlong stem, which I didn't know. I've never seen that before. But you can actually go back and then read about it and then try and figure it out. But that's a valid point. You must know what sort of implant has been used to have an appropriate strategy in place to remove it properly.
So with this experience, you have become a software by yourself.
That's right. That's right.
So if someone has any doubt regarding which implant, they're going to send it to you.
You're always welcome. So if I can help, I can.
Yeah,
So
sure.
usually with time, you've seen so many things, and it's always a good idea to keep looking at the published literature and then look at all the implants and have a feel of those X-rays, and you should read extensively. So then there's no substitute for that.
Thank you for that. The other question is, see, when you do a cement in cement revision, that's what you mentioned. Like you don't take, suppose you're unable to take the remaining cement. So that's when you go in for a cement in cement revision, isn't it?
No. If we have a well-fixed, well-positioned, collarless polished taper type of stem, like a C-stem, Exeter, or a CPT, with a good cement bone there's no lucency in any of the zone. So you want to do a, but you don't want to retain the original stem for offset reason or the trunnion damage or something like that. There are two choices. If you can retain the same stem, you can just put it back in. So you knock it out, do your acetabular revision, put it back in and get out. That's called in cement revision. So it's not cement in cement, it's in cement because you're using the same implant. The second option is to use a collarless polished taper stem, which is one size smaller than the one which was put in previously. So this has prerequisites. The stem must be in the center, acceptable position. The cement bone interface must not have any lucencies. So you must look at the stem and say, okay, this I can accept. I don't need to revise this at all. So then I will do a sort of take a burr, freshen the cement mantle. I will not try and remove the cement at all. Retain the cement mantle. Take a fresh batch of cement, 20 or 40 gram cement, push the cement into this existing mantle after freshening the surface, and then use a new stem into this particular thing. And we will not use a centralizer in this particular thing. So you cannot use a sort of a flower type of centralizer for that because it will not go into that mantle. Precautions for this: you should not use a very small stem because it will subside into that mantle itself. So the length of the stem must be equivalent to the length we have removed because you should not allow space, too much space for that stem to subside. Second prerequisite is the stem positioning in the canal in the AP lateral views must be independently acceptable to you. The third prerequisite is that the cement bone interface must not have any lucencies. So these are the three prerequisites. So if it's
Yeah, now see, when you remove, unless you remove some amount of cement, how do you insert the remaining part of cement? Because there's no space in there, isn't it? So you may have to remove a small.
Once you remove the stem, whatever space is there, you put cement into that. And then you put a new stem. The reason is you don't want that new stem to just subside. If there is a minor mismatch, that is taken care by the cement as a grout.
And are you worried about having a periprosthetic intraoperative fracture at that moment?
During the new stem insertion?
Yeah.
That's why I told you, you must choose a stem which is one size smaller than the previous stem. So it's in cemented, you can do that. You can put more cement and use a smaller stem. So you have 00 option from CPT. You have the 30, 33 and 35 options from Exeter. And you have the short length Exeter, which is also available. Okay, so
that is a precaution that we need to take, that we put a smaller size stem.
One size smaller. Yeah, one size smaller. Yeah.
And Krishna, some of the X-rays, I mean, you've shown exemplary work, no doubt about it. So see, sometimes I've seen some of the pictures after you do an ETO also, there is some bone loss in some of the parts of the femur on the inner medial side. So why do those occur? I mean, I've seen that, in the previous image, the bone stock was good, but after that, once you do the
so it can happen with the highly porous coated devices. So in these cases, we not only do a ETO, we also do a controlled segmentation of the femur. So it is not only ETO, but the medial side also you will have to cut it out, but we will not remove the soft tissue or anything. We may have to do a transverse cut and then take it out in certain situations. So that is when it happens, but it doesn't matter actually. You just put everything back and wire. It acts like a fracture and it will cause a lot of new bone formation in the next 6 to 9 months time. So it's not a big deal.
So that one which you showed was an AML stem, isn't it?
Correct. So the AML stem is an intentional thing. So the ETO itself may not be enough. So we will do a sort of a transverse osteotomy distally also onto the medial fragment so that it becomes easier to remove it. But it will be in one piece. So you'll have one medial long piece, one lateral piece, which are put together, wired back, and then that fracture is fixed with a distally fixing stem.
So AML is one of the most difficult stems to extract.
Absolutely. So it's a nightmare. So there I've around 8 or 10 times when I've had to do that. So now we have devised a technique where we would do the ETO to start with, take a fresh saw blade and saw off the remaining part of the thing. And there is no compromise on that. You must do the osteotomy till that porous coating. So there is no point in doing a short osteotomy and then struggling to remove the remaining part of the stem. Believe me, it's extremely difficult. So we make a plan. So the length of the stem and the osteotomy is done right up till the tip of that stem, except the last part of it, which is non-coated. It's a bullet tip. Till the coating, we make a osteotomy, lift it up, take saw blade, and then proximally we nibble out a little bit of calcar part of it, introduce a giggly saw, and then take out the thing. So now we have actually become better at doing the AML also, but it takes a lot of time and it's a nightmare.
And is there a scenario where you have to cut the implant?
So there is a scenario where there is a long AML stem or like a solution stem, which has which has failed, or infection. There is an infection, so that you cannot remove without cutting the implant, because you can't do a full length ETO. So what you do there is you do an ETO 120 millimeters or 12 centimeters. At that level, you free the implant out and take a metal cutting burr and cut it out. Take a metal cutting burr, cut that proximal part out, and then distal part is cylindrical. So now you have trifines which are 12, 13, 15, 17 millimeters in size, and the length of the stem. So you put it over the top of that broken or the where you have broken the thing, and then you take a drill and then go on top of the stem between the porous coating and the bone, and that is how it will get loose and it will come out. The trifine is again required when there is a broken solution stem. So we have situations where the solution stem breaks, because if you don't have proximal bone support and you just have distal fixation, you don't have proximal thing, and you've used a cobalt chrome stem, it will break after 5 to 7, 8 years. So we've seen a few of these where it will break. So then you need a trifine to remove the distal part, because that is well ingrown.
Both are fully coated, is it? Solutions as well as AML.
Absolutely. So AML is a shorter version, solution is a longer version. So we have now moved away from the fully coated stems. So we now use the titanium grid blasted stem, like the Wagner. It's a monoblock stem. It works. It's up to 305 millimeters in length. So it works for most of the situations. Usually, you should use the shortest possible length in these, because the shortest possible length will give the greatest stability. It's not necessarily the length.
Now, see, suppose you have removed the AML stem. Okay, and now what is the next implant that you're going to put in, or solution stem?
So if it's a AML stem, you can either use a solution or a Wagner stem. So the length usually will be 225. Sometimes, if you're lucky, you can do a 190, but it's usually a 225 Wagner. So for a solution stem, you will have to be prepared with modular interlocking type of devices like the reef, or you have the other modular stems, which are proximal distal mid-stem modularity stems, which are available from Zimmer, Stryker, and all of these companies.
See, just a basic query. See, suppose you've removed an unsymmetrical stem like an AML or a solutions. Can you do a cemented revision after that? Is it possible?
It is not advisable, because the bone, cancellous bone, would have been damaged. So the cemented stem would normally work on a cement into cancellous bone interdigitation. So although you can get away in a short term by, you have osteotomized everything and then you put a long cemented stem, there is a potential for non-union there. And also this doesn't give long-term durable fixation. So in our hands, we don't tend to use long cemented stems anymore for revision procedures. It's only for
uncemented stem, you're going to revise it with again an uncemented stem, isn't it?
Yeah, absolutely. Any revision, we don't use cemented stem unless it's a cement in cement revision. We have gone away from cemented revision stems, because universally the literature shows poor outcomes for long cemented stems. And then if you have to revise that for some reason, God forbid, what will you do? Because it's again a big problem. Yeah. So our workhorse today is the monoblock Wagner type of device. So we won't use any modularity wherever we can help it. Wherever possible, we'll use the monoblock device of the shortest length possible, which will give 2 cortical diameter bypass from the osteotomized segment or wherever we want.
And I remember in some of the x-rays that you've shown that in a cemented stem, you were able to remove the entire piece of cement as well, isn't it?
Yeah.
And in those cases, would you think about doing an uncemented stem? Revise it with?
Once we've removed the entire cement,
Yes.
definitely uncemented revision. So Again, the options, you can do an impaction bone grafting if you're very good exeter trained or something like that. Our hands it's not worked well, so maybe it's faulty technique or something. So we do something which is more predictable. So today, all revisions get a monoblock Wagner type of stem. That's it. So we don't do anything else. That's the same stem. We've gotten good at it, and the outcome is predictable. So that's what I would suggest.
Uncemented.
Uncemented, yeah, uncemented.
So uncemented monoblock Wagner type of stem is your workhorse for femoral revision.
Absolutely.
That's the bottom line.
That's the bottom line for me. Yeah.
Okay. I think Krishna, fantastic talk, and what great examples you've shown. I mean, these are things that are not available sometimes even in conferences. Thank you so much, Krishna. Thank you once again for joining in, and really look forward for some of your work again.
Thank you very much, Hitesh. Thanks for having me.
Yeah, thank you. Bye-bye.